So it's a little bright up here because thankfully Clint we had a little issue with the lights up here. But I think it will work out perfectly. Thank you and welcome to coming to Grand Rounds again this morning. So before I introduce our Grand Rounds speaker, I have just a couple of things to say and announcements. So first of all, holiday times are coming up again. And Thanksgiving is coming next week, so I won't see any of you before Grand Rounds. So this is really my time to give thanks to all of you as we start this holiday season for whatever you do that makes our department great. I truly believe we have the best Department of Medicine in the country. And whether you're a clinician, whether you're a researcher, whether you're a teacher, or whether you support us in the work we do, thank you very much. And so I hope you get to take at least a few minutes or a day to spend time with the people you love or the animals you love or the things that you love, because really when it comes down to it, family is most important of all. So I wish you well during this time and a lot of safe travels too. So 2 announcements. My first announcement I couldn't make last week because the whole university wasn't aware of it yet, but I am very happy to announce that Dr. Lynn Schnapp has accepted the offer to become our next chair for the Department of Medicine. That's fantastic. She's going to be starting on March 1st, and she's coming to us from the Medical University of South Carolina, where she is the division chief for the Division of Allergy, Pulmonary, Critical Care, and Sleep Medicine. And more to come on that. I'm hoping that she'll be able to spend some time with us before she gets here, and you'll get to meet her at one of our grand rounds. Finally, please, if you have not done it, fill out the wellness survey that has been coming around. I sent out a little note about that, but it is a critical core value for me that we work on wellness, and our department has the lowest response rate at this point in time. So please, it's probably not a good thing. So please fill that out. So with that, I am very honored to present one of our own faculty who's going to be giving grand rounds today. This is Dr. MD, MPH. He's an assistant professor, CHS track in the Division of Gastroenterology and Hepatology. I'm going to just tell you a little bit about Dr. Lomeli right now. He started out his medical training getting an MPH in epidemiology at the University of Illinois, Chicago. He then went on to complete his medical degree at the University of Illinois at the Rockford campus. He did his residency at the Mayo Clinic, and he then went on and joined us on faculty and did his fellowship in gastroenterology and hepatology. And in 2017, when he completed that, we were very lucky to have him join us here on faculty. And as I told him before this talk, giving grand rounds is an incredibly stressful endeavor, and he is very accomplished and very brave to get up here and give grand rounds when he is really one of our newer faculty, which is fantastic. So a little bit about him as far as awards and honors. In 2016, he received the Department of Medicine 3rd Annual Fellowship Quality Improvement Showcase Award from the Department of Medicine, and that was for one of the areas that he is really interested in. And that presentation was titled, let me just get, Eosinophilic Esophagitis, Practice Variations in an Emerging Disease. And when I talked to him just a little bit about before the grand rounds, he is really interested in eosinophilic esophagitis, something that is an important area of exploration, and also interested in quality improvement. So I think it marries 2 fantastic things together. He's also been very involved in teaching early in his career, working with medical students, both in case-based sessions and in food, fasting, and fitness. And with that, will you please come up and give us grand rounds?
All right, thank you very much for having me. I'm going to put this fancier mic on as well. Let's see if it works. Okay, oh, perfect. All right, so I'll start off by just asking you if you can think about how many patients you've encountered with asthma or inflammatory bowel disease. And likely you've encountered many patients with those conditions, and I'll have you know that the incidence of eosinophilic esophagitis is now equivalent to both of those conditions. So it's becoming very common. And it's one of the things that we're seeing very often in an emergent basis in the emergency department, where we have to retrieve food from somebody's esophagus. And we'll go into that in a little bit more detail. I have no relevant financial disclosures, and I will be talking about some off-label use of medications and devices. After this talk, I would like you to be able to define eosinophilic esophagitis, recognize its changing epidemiology, identify the diagnostic and management strategies of EoE, and then be familiar with new developments in the field. And in addition, throughout the presentation, I'm going to pause and we're going to talk about some key points throughout the presentation. Initially recognized as a distinct entity about 25 years ago, you can see that since its first published guideline in 2007, a lot has changed. And there's been many new updates in the guidelines since then, with the most recent, this was probably even a more recent one since that one in 2018. And currently, EoE is defined as a chronic allergic immune-mediated disease that is characterized by symptoms of esophageal dysfunction, with eosinophilic infiltration on biopsies of the esophagus. And you can see here, the eosinophils causing inflammation throughout the esophagus in the absence of other causes of eosinophilia. And EoE has truly emerged over the last 2 decades as a cause of major upper GI morbidity. And as you can see here, where initially it was a case reportable condition, now we can see it throughout the world. So it's very common. And all studies looking at the incidence of EoE have also demonstrated a rapid increase in its rate. And what this chart is showing is the incidence on the y-axis, and each one of these lines represents a different study. You can see that all of these studies are demonstrating a rise in its incidence. Now, there's a lot of variability. If we pool all those incidence rates, it's about 3.7 per 100,000 per year. And like I mentioned before, that's equivalent to asthma or inflammatory bowel disease. Now you can say, well, is this incidence, this increase in incidence, only due to our increased recognition of the disease? And that's part of it. However, there's likely another component. And this study showed it nicely. This is out of Denmark, where they have the ability of tracking biopsy results a little better. And on the left y-axis, you have the incidence, and that corresponds to the 2 bottom lines. And you can see that the incidence of EoE is rapidly rising. On the right y-axis, you have biopsy rates, and that corresponds to the top line. And you can see that that's also rising. However, if you note that the incidence of EoE is increasing much more rapidly, and it far outpaces the rate of our biopsy utilization, which really suggests that there's some other reason why this incidence is rising. In addition to the geographic variation, we also see that the prevalence of EoE differs among clinical populations. And whereas normally we expect the prevalence to be about 0.5 per 1,000 persons, you can see here that when we do an endoscopy for any reason, we can identify EoE in up to 6% of our patients. And it increases when we change the indication from reflux to about 8%, dysphagia, 23%, and then food impaction, where the food is physically stuck in the esophagus. We diagnose EoE very commonly. And you can imagine how uncomfortable that is, where people present with just the food being stuck. They're unable to tolerate any of their secretions, any liquid, and we have to come in emergently to remove it because it can cause harm if we were to leave it in. And EoE has now become the most common reason why food impactions occur. This study was looking at the diagnosis after a food impaction. And you can see that if we break it up in 5-year increments from 1995 to 2010, if you look at the bars, you can see that gradually we're seeing a decrease in acid reflux related causes of food impactions. So we're seeing less of these Schatzki's rings or the strictures at distal esophagus. We're seeing less peptic strictures, and we're seeing a rapid rise in EoE. So why is this happening? Well, some studies have demonstrated familial clustering, and so what could it be? Partly genetic, and that does play some role. And as you can see here, when we look at twin studies, when you compare monozygotic twins, identical twins, they have a much higher rate of developing EoE. However, what was most interesting about this study was the fact that dizygotic twins, so fraternal twins, not identical, they have a much higher risk of developing EoE compared to siblings that are born at different time periods. And this really suggests that familial clustering is likely related to a shared common environment. So for some reason, some exposure that they grew up with is leading to an increased risk of developing EoE. And that has been investigated. So they're looking at, well, could there be early life exposures that could explain or can increase the risk of developing EoE? And in this chart, the higher above the line, the increased odds of developing EoE. And in the prenatal period, one risk factor would be a maternal fever, whether that be that the mother is exposed to antibiotics. And in the postnatal period, you can see that antibiotics has been associated with an increased risk of EoE, and interestingly, acid suppressants very early in life. That's pretty neat because we'll be discussing how acid suppressants are actually one of the treatments that we use for EoE in adults. Environmental and aeroallergens have also been investigated, and this chart describes how we actually tend to diagnose EoE more often during different parts of the month, and most commonly during allergy seasons, which is pretty neat. You think that why would allergies then cause inflammation in the esophagus? And that brings us to one potential theory, which is that of the atopic march. And the theory is that, well, if there's inflammation somewhere in our body, then potentially it can then progress and then get into our esophagus. And because we do see that in earlier ages, on the chart on the left, most often atopic dermatitis is the first manifestation of allergic disease, followed by IgE-mediated food allergies, asthma, allergic rhinitis, and then EoE is usually a later manifestation. We also see that EoE and IgE-mediated food allergies are very strongly related. Ultimately, like any disease, there's likely a combination of factors, and it involves somebody who is genetically susceptible, who is exposed to some trigger at a critical window of their life that then changes their gene expression, potentially changes their microbiota. We still have a lot to learn about that, which then leads to development of a disease later in life. And EoE can occur in patients of all ages. So you can see here that there's a wide spectrum. However, it is most common in Caucasian males who have a history of atopic disease, and it occurs most often in the mid to late 30s. That's the peak age. And it can present as a spectrum, where in adults, we tend to diagnose patients on this side where the inflammation has likely transformed, caused narrowing and stricturing of the disease, which then leads to trouble swallowing, food sticking, and food impactions. Whereas in the pediatric population, it tends to be different. So they likely present to this inflammatory state where they experience more vaguer nausea, vomiting, food intolerances, and likely this represents a progression from an inflammatory state to a fibrotic state. So I'll pause here for a second to summarize what we've been talking about. So first, very common disease, and the incidence is rapidly rising. It affects people of all ages. However, it is most common in the late 30s, Caucasian males with a history of atopic disease. And solid food dysphagia is the most common symptom in adults, and it's now the most common reason why patients present with a food impaction. So we've talked about the first 2 points. Now we're going to talk about diagnostic and management strategies. So the diagnosis of EoE starts with an upper endoscopy. And as you can see here on the left, this is a normal esophagus, looks nice and pink. You see the little red lines, which is the normal vasculature of the esophagus. And on the right, you see how it looks very different. So on the top left, you have an esophagus that has these fixed rings throughout the esophagus. On the top right, you have these lines that are coursing down the esophagus that are called furrows. On the bottom left, you have these little white dots, which are called exudates. Those are rich in eosinophils. And on the bottom right, you have a food impaction. And likely there is a stenosis below that food impaction as well. Now, there is a normal variation throughout the GI tract as far as the absolute normal number of eosinophils. However, I will have you note that in the esophagus, it is not normal to have any eosinophils. And by consensus guideline, we say that if we see above 15 eosinophils per high power field when we take a biopsy of the esophagus, that's consistent with EoE. It's important to know, however, that EoE is a very patchy disease. And you can see here that each of these lines represents a patient. And within a patient, there's significant variability depending on where we take the biopsies. So they can be higher in the bottom, the distal part of the esophagus, can be higher in the proximal esophagus. So it's very important that we take adequate biopsies. And biopsying the scar tissue does not produce results. So we don't see those eosinophils when we do that. Even more interesting, I'll go through this study. What they did was, so each number is an individual patient. And what they did was they took biopsies from the bottom of the esophagus, and they took from every centimeter up the esophagus. And then they looked at what the eosinophil count was. And you can see here that for every patient, what the dramatic variability of all those little dots are, and how the eosinophil counts can vary significantly depending on where we take the biopsies. I bring that up because it's important that if the results are not clear-cut, potentially it may require taking another look, taking some more biopsies to understand exactly what's going on, because the diagnosis might have been missed. So the way that we would diagnose EoE, as I mentioned before, is really to start off with an upper endoscopy. We identify eosinophils in the esophagus, and then historically what we would do is we would treat them with an acid blocker, a proton pump inhibitor, typically 40 milligrams twice a day for 2 months. We would repeat an endoscopy, and then if the eosinophils were still present in the esophagus, we would call it EoE. However, if they responded to the acid blockers, we weren't really sure. This was a little trickier. Could this represent acid reflux? Could this represent a milder form of EoE? And I'll go through that. First thing though, as the only finding, esophageal eosinophilia has a very broad differential diagnosis. Yes, the two most common are EoE and acid reflux or GERD. However, you can see that many different conditions can cause eosinophils in the esophagus. So it's important to consider that before you go down the management pathway. Fortunately, most of these can be identified just with your history or with endoscopy or any other comorbidities that your patient might have. And so when we focus on our first line therapy and that algorithm that I mentioned starting that proton pump inhibitor, you can see that most people respond. And so these are all individual patients, the eosinophil counts before and after PPI therapy, and you can see the dramatic improvement in eosinophils. Now, it gets a little more complicated because you think, well, we used to use this as a way to determine or differentiate between acid reflux and this true allergic condition, EoE. But interestingly, even among people who have symptoms consistent with acid reflux, the pyrosis, the burning, regurgitation, there's still a 20% chance that they will not respond to PPI therapy. On the other hand, even those that have no symptoms of acid reflux and they've undergone a special test, they put a catheter in their nose, it measures how much acid is coming up into their esophagus, they have absolutely no acid reflux, about a third still respond to PPI therapy. And so why is this happening? Why are the PPIs so effective in treating this disease? We do struggle, though, predicting who is going to respond to the acid blockers. As I mentioned before, it works really well. And when we look at the typical features of EoE, as I mentioned before, the main ones are the fixed rings, the exudates, and the furrows. We cannot determine who is going to respond. You can see that the EoE and in this case, the PPI responsive esophageal eosinophilia, or those that respond to PPI therapy, look identical. And interestingly, we can also not predict based on the absolute number of the eosinophil count. The eosinophils could be up into the hundreds, and we can still see a response to PPI therapy. And this is one of my patients who presented with a food impaction. You see it on the upper left. And on the bottom left, you see classic features of EoE with a pale-looking esophagus. You don't see as much vasculature, those little red lines. You see those longitudinal lines called furrows. And when we biopsied it, we saw that there were up to 50 eosinophils. we started the PPI trial, and you can see how different it looks. One, the histology completely normalized, and second, the esophagus looks nice and smooth. You start seeing those you see the nice little red lines, the vasculature. It really works. And so, how does this happen? Why does this work? Well, one theory has to do with the tight junctions in the esophagus. And what I mean by that is the esophagus, as you know, is lined by these little cells, and they're supposed to be squished up really close together, and they're not supposed to allow anything to cross the esophagus. And this study was done in mice, but what you can see here is that on the left you have a normal esophagus. On the right, you have an esophagus that's been exposed to acid. And you can see that the intracellular spaces are dilated. And it's been actually shown that tiny little microscopic amounts of food can actually cross. Antigen-presenting cells can grab these little things and then cause this allergic reaction. So could that be a mechanism, and could that be why PPIs work, these acid blockers? Could it be that we're just healing the mucosa and then not allowing the allergic reaction to occur? Well, this has also now been demonstrated in people. And you can see here on the left, you have somebody who has EoE. You can see the dilated intracellular spaces, and then after a PPI trial. In this case, they did not respond. So you see that they're still dilated and not normal. On the top right, you have somebody who did respond. So this older term that we used to use is PPI responsive esophageal eosinophilia. So they responded to the PPI therapy. And I think you can appreciate that the intracellular spaces are dilated in the top right, and then they normalize below. So it really does work. It does heal the esophagus. Even more interesting, EoE, the EoE can also be treated with PPI therapy in a completely unrelated to acid reflux. So this study showed that PPIs can actually independently downregulate eotaxin 3. And eotaxin 3 is one of the main chemoattractants that brings the eosinophil to the esophagus. And so could PPI therapy also just have an anti-inflammatory effect? To make it a little harder too, when we look at gene expression maps, so really looking at the colors, you can see that EoE and those patients that respond to PPI therapy, those PPI responsive esophageal eosinophilia, look identical. So you can see they all look blue, they look very similar, so we just cannot tell them apart. And those that respond to PPI therapy completely normalize their gene expression. Lastly, to add one more slide about this data and how intermixed they are, both patients with EoE can respond independently with PPI therapy and with diet. And we'll talk about diet therapy in a few more slides. But you can see that in the baseline, significantly inflamed, a lot of furrows, exudates, little white dots, and then it just normalizes. And this has really changed our paradigm, kind of how we think about EoE, because we used to try to separate acid reflux from EoE, and we used to use the PPI trial to do so. And then later we learned, well, maybe they're kind of similar. They're not exactly two things that we can separate. And we made up this new disease called PPI responsive esophageal eosinophilia. However, I think with the most recent data, we're learning that it likely represents a continuum, so it's a spectrum, and they're both related, and they both exacerbate one another. Even then, we still are trying to predict how we should use this PPI therapy. So this is one of our studies looking at patients who did not respond to PPI therapy initially. And we always struggle with the question, who should remain on PPIs if it didn't normalize the histology to 0? And so we're looking, well, maybe we can predict if we see features of acid reflux. And in this case, we thought of reflux-prone patients were patients who had a hiatal hernia, Barrett's esophagus, or esophagitis on endoscopy. They did not have a complete resolution of their eosinophilia, but you can see that they had some improvement, and maybe they would benefit on staying on therapy. So we need to look into that a little further. Now we're going to switch gears, so we're going to talk about medical therapy, diet therapy, and dilation as well. Before we do that, I think it's very important to discuss the natural history of the disease. I think it really guides us as far as knowing the prognosis and tells us how to manage our patients. This is probably the best study that we have. So it looked at patients and followed them for about 12 years on average. And these were patients who were not treated. And you can see that these symptoms, which are the dark black line, really doesn't shift too much, so it stays in that 90% range. Some of these patients did receive esophageal dilation, and so that's why we see some improvement, but it stayed. And the eosinophil counts did not normalize. And really what this study stresses is that EoE is a chronic disease. So if we leave it untreated, it is going to progress. They also looked at what will happen if we treat them, they're in histologic remission, and then we stop all therapy. So in this case, they achieved remission. They either separated them into a placebo arm or a fourth of the dose of what we typically use with a swallow topical steroid, which I'll talk about in a little bit. And you can see that on average, on those that were on the placebo group, the inflammation, all the symptoms recurred in about 3 to 4 months. In the patients that were on the fourth of the dose of budesonide, it took a little longer, but they also recurred, usually in about 4 months or so. And they also demonstrated another finding, which is really interesting, that this inflammation likely has long-term consequences. Now, these are pictures of an endoscopic ultrasound of the esophagus, and the arrows are pointing to the laminar propria of the esophagus. And you can see that in the normal patient, the laminar propria is a smaller size, is a thinner strip of tissue, and you can see how much thicker it is in patients with EoE. Even after treatment, some of this remains, and this suggests that this inflammation really has longer-term consequences. It's causing fibrosis throughout the esophagus. And most recently, it's been demonstrated that the eosinophilia, yes, it's most common in the epithelium. You can see the range of the tissue eosinophils in the epithelium, but it's also present throughout the rest of the esophagus and even into the muscular layer of the esophagus. And when we do special staining, trichome staining to look at fibrosis, you can see that the blue band is all the fibrosis throughout the esophagus, and it can reach the muscle layer as well. And really what this means is that over time, the inflammation, the irritation that we see in the esophagus will then progress. And when it progresses, it leads to fibrosis, stricturing, and this study demonstrated nicely. So what they did was they used a balloon that can inflate in the esophagus, and with that balloon, they can also measure the cross-sectional area of the esophagus. And on the bottom, on the x-axis, you have the volume that they're filling the balloon. On the left y-axis, you have the cross-sectional area. And you can see that in controls, as you inflate a balloon, the esophagus adapts. It's very pliable. It opens up. But with EoE patients, it doesn't. And when we look at the absolute diameter of the esophagus, many patients will have strictures. You can see that the normal esophagus is upwards of 20 millimeters in size, and in the EoE patients, it's much lower, it's in the 13 millimeter size range. And you can see it very clearly as well in this esophagram, where you have a normal esophagram on the left, nice and open, and on the right, you see how thin it can be, and the entire esophagus can actually become narrow. In addition, with each year that we delay the diagnosis, there's an increased risk of developing strictures. On average, if we wait 10 years to start treatment, there's a doubling of the fibrostenotic phenotype. You can see here by year 8 to 10, there's a significant increase in this fibrotic phenotype. And unfortunately, we're diagnosing our patients very late. And most of this occurs in our younger individuals. We can see in the pediatric and in the 10 to 20-year-olds, the average diagnostic delay is about 10 years. And by then, they're going to have a stricture. And that's a combination of factors. One, maybe we're not bringing them in to do the test soon enough, but also because this is such a slow and chronic condition, people adapt. So they feel that things are sticking, they start chewing their food a little better, they alternate their solids and their liquids, and then they do okay. And one classic example, one of my patients who had an esophagus that was about 8 millimeters, so less than half the normal size. And he was doing fine. Every time he would come into clinic, he would tell me, no trouble. He's eating everything. He was in good health. He's still exercising, but he was adapting. So, and the main risk is that we don't want it to get worse. So we'll talk about that. So we're going to pause here again and just talk about the brief summary. So one, we diagnosed it with an upper endoscopy, and we need to take biopsies throughout the esophagus and enough quantity to really establish the diagnosis of EoE. PPIs work. They not only treat acid reflux, but independent of acid reflux, they also remove the eosinophils from the esophagus. And then I'll stress that it's a chronic disease. So we now know that left untreated, it will progress, and it's important to establish a maintenance plan and continue to monitor these patients because they really minimize their symptoms. We're going to move forward with treatment. And we've already talked about PPI therapy, but we're going to move on to other medications that we have available. The first are the swallowed topical steroids. Now, unfortunately, we don't have an FDA-approved medication for EoE, and so all these medications we borrow from people with asthma. In our case, instead of having our patients use the budesonide, put it in their nebulizer and breathe it in our case, we want them to crack it open, mix it in something thicker like honey or anything they have available, sometimes even like maple syrup or some kind of chocolate sauce. I've had people try all sorts of things. And then swallow it. And then when they swallow it, it coats the esophagus, and then the contact time really heals the esophagus. So so budesonide is one option because it comes in a liquid. Fluticasone can also be used, so it comes as a powder. A little trickier, but there's actually a video where you can kind of instruct your patients. They actually have to crack it open, take out the little blister packet, open them up, and then put the little powder in their mouth and swallow. The last option is fluticasone, but it's a spray. So that's the tricky part, is that because it's a spray, it's not as intuitive as far as how to take. Sometimes we're limited as far as what therapies we can use, and fluticasone, it still works. It's important to know the dose, though. So usually it's 4 puffs twice a day. But the reason why I was alluding to how it's important, we prefer the liquid formulations or formulations that make a little more sense, is because unfortunately when they have some studies radio-labeling the medication, you can see that in the fluticasone group, a lot of it goes into the lungs. So patients are probably not taking it correctly, they're puffing, they're inhaling, it's going into the wrong place, versus the swallowed liquid therapy goes into the GI tract where we want it to go, and we want it to stay in the esophagus. Besides swallowed topical steroids, diet has also taken off as a really good treatment. Unfortunately, to this date, we don't have a skin test, a blood test, some way to predict which one of these triggers is going to be. However, it has been identified that the 6 most common triggers are wheat, dairy, eggs, soy, fish, and nuts. That covers about 75% of the trigger, so even then we might miss it, but it works really well. And you can see here that when patients were treated with the 6-food elimination diet, most of them responded. The eosinophils just melted away. And you can even see it on the pictures where pre-diet, it looks really inflamed, very irritated. Post-diet, significant improvement. There's still a little bit of inflammation on some of those pictures, but significant improvement. And then when they were challenged with their specific trigger, everything just recurred again. The tough part is that it requires a lot of endoscopy. So currently, we don't have a way to determine when the esophagus is inflamed. And so what we do is we ask our patients to do the elimination diet, and then we repeat an endoscopy. When we take a look, if things are perfect, then we start adding typically the least allergenic triggers, and then we do a repeat endoscopy. So they're good, we add fish and seafood, we do an endoscopy. If things continue to look good, then we add soy and eggs. If things look good, then we add dairy and wheat. You can imagine that's a lot of endoscopy. But I think the long-term plan, if we don't have to use medications and treat it with diet, it really works well. Now, some have mentioned, well, out of all those 6 triggers, what are the most common? The most common are actually wheat and dairy. So can we just eliminate those instead of doing the 6-food elimination diet? And it works. It's less effective. So the percent effectiveness varies, but it's about 50%. So in a way, if you're one of the lucky ones that has just dairy or wheat allergy as a cause of their EoE, then by eliminating those, then you can find it without going through such an extensive diet process. I would say, though, that it's very important that when you undergo these diets that you plug your patient in with a dietitian. We're fortunate that we have 2 that are focused on EoE because when you go through it, you want to make sure that they do it well. It's 2 months of their life where they have to really change what they're doing. It affects their family. It's expensive, and we want to make sure they do it well so that we only have to do it once. That's the important part. But within our group, so Dr. Mathur here in our allergy department is looking at, well, can we identify a biomarker? So can we do a blood test to detect when somebody is inflamed? That would be so amazing, because you can think of how many endoscopies we have to do. If we can start the diet and then do a blood test to figure out whether they're responding, that would be amazing. And so we hypothesize that a surface marker of an eosinophil can predict whether somebody is inflamed or not. And so we recruited patients who had undergone a PPI trial. They had persistence of their eosinophils, and then they were treated with either a 6-food elimination diet or swallow topical steroids. And what we found was actually very good, because we can see that, one, it can predict when the eosinophil count is above 15 or below. And when we look at ROC curves, you can also see that the alpha-2 beta can really predict when the esophagus has less than 6 eosinophils per high-powered field. So this is great research. So it'd be wonderful if we didn't have to do as many endoscopies while doing the 6-food elimination diet. In addition to medical therapy, esophageal dilation plays a key role in the management of our patients. And the method that we use depends really on where the narrowing is. And this is a trick question. So can anybody see a narrowing in the esophagus? So a trick question. So actually you're not supposed to be able to see one. And the main reason why is because if you think of the esophagus as a tube, as we're looking through the esophagus, it's very difficult to assess the relative diameter. It's easier if the scope snags on the esophagus, then we know that the esophagus is narrower than the scope. But otherwise, if you don't get that sensation, you could miss it. And this patient that looks nice and open, when they did in the study, their high quality esophagram, you can see that their esophagus measured in the 10 to 14 millimeter range, so half the size of what we normally would expect. And when they looked at the rates of how well we can diagnose strictures, when they're less than 16 millimeters in diameter, so normal is still greater than 20, we have a sensitivity about 25%, so we still miss a lot of them. When we bring it down to 14 millimeters, we get a little better, but we still have a sensitivity about 33%. And that's very important because narrowings in the esophagus can really predict when somebody's going to present with a food impaction. On the left, you have different grades of rings of the esophagus, from very mild rings on the top to more distinct rings in the middle to severe rings. And severe rings are those that do not allow our scope to pass. Our scope is about 9.5 millimeters. And so, yeah, it makes sense that if somebody has a very narrow esophagus that not allow the scope to pass, they're more likely to develop food impactions, and they're also more likely to develop self-limiting food impactions where it might resolve at home. But it's important to know this grade 2 because there's likely some stricture there, so we really have to look when somebody has dysphagia. And these are 2 of my patients. On the left, this was actually a more obvious one, so actually the scope didn't fit, so I knew that they were very narrow. On the right, you can't really see a narrowing, but it almost felt like it snugged a little bit, and that led us to do a dilation. And this is actually what we want to see. So we want a controlled tear of the esophagus. We're disrupting that scar tissue, and it actually makes a significant improvement. The most important thing, however, is to know that, one, it is very safe, and most recent studies are demonstrating that there is not an increased risk of dilation in our patients with EoE compared to other patients that we do dilations for. The most important thing, though, is to go slow, and that's what we do. We want to be as careful as we can so that we don't cause harm. And so to summarize our overall management of EoE, because it really has changed, is to first think about EoE, do an endoscopy with biopsies. If you see eosinophils, think about other causes of esophageal eosinophilia. Once you've thought about them, you don't think that's the cause, then you really have options. You have options as to how to treat it. You can either use medical therapy, starting with PPI therapy. You can talk about diet therapy. Esophageal dilation plays a role. And then the last but most important, I think, is maintenance therapy. So we want to make sure that people stay on their therapy. And it actually works. So this is a study that followed patients for 10 years on treatment, and you can see that most patients, the blue part, have an unlimited diet without caution. So they can do very well with treatment. And the other piece of the pie, still an unlimited diet with caution. So most people treated with EoE can do very well. And when we look at symptom scores, we also see that there's improvement with time. Ultimately, what's going to become more important is trying to manage our patients in a cost-effective way and try to, because it's a big burden to our medical system as well. However, I'll kind of guide you through this chart. One is things start with symptoms, of course, and the first thing to try to improve upon is our diagnostic delay. As I mentioned before, we take about 10 years on average to diagnose our patients with EoE, and that leads to worsening of strictures. People may require more dilation, so that costs. If people present to the emergency department with a food impaction, that's also very costly. It's a very life-altering event too for our patients. And then, of course, if they're admitted after a food impaction with a complication, then that also adds cost. So I think the most important thing is thinking about that, bringing them into clinic early, starting off with dilation, medical treatment, and then really focusing on a maintenance therapy that works for your patient. So if they're upfront and they don't think that diet will work, then choosing medical therapy as opposed to that. And one thing we're focusing on here is, well, how can we improve that? How can we improve our management of EoE? And the first thing we focused on was PPI therapy. And what we did was we collected kind of how often we were using PPIs to treat our patients with EoE. And then we did several educational sessions. And as you can see, our rates of using PPIs has dramatically improved over time. We've also been using more of the slurries, and our elimination diets has increased significantly. One area that we still need to work on is what happens to our patients after they present with a food impaction. And you can see here that in our patients with established EoE, we recommend that they come back 50% of the time, but you can see that only a third actually come back to clinic sometimes. In patients who we do the endoscopy, they have a food impaction, we think they have EoE, we definitely recommend they come back, but only about 50% come back to clinic after the food impaction. We often prescribe a medication to try to see if we can heal the esophagus. And on average, fortunately, people don't have recurrence of food impaction most of the time. And I think that's mainly because they adapt. Once it's happened once, they're going to chew their food really well. But it's very important to bring them back because the last thing we want is for that to occur again. To summarize the treatment, really things have shifted where ideally we want to use a therapy that's tailored to your patient. PPI therapy as first-line medical therapy, swallow topical steroids, and diet therapy. And I'll stress again that it's a chronic disease that requires maintenance therapy. The last thing we'll talk about are new developments in the field. And I mentioned this briefly on a previous slide, but this is called the EndoFlip, and it's a balloon that we can place while somebody's sedated and place it down the esophagus. And as we inflate the esophagus, it can precisely measure the diameter of the esophagus. And this will be really useful because, as I mentioned before, we struggle with identifying very subtle narrowings of the esophagus. And if we can find them, predict very reliably how narrow the esophagus is, then it can also guide our therapy and make it safer when we do our endoscopies with dilation. Other less invasive testing, this example is the esophageal string test. So they swallow a little capsule, it's attached to a string. As the capsule goes into their stomach, it dissolves, and then they can pull out the string and they can measure whether there are eosinophils or products of eosinophils within the string. Another thing that's been developed is the cytosponge. So just same idea, there's a pill, you swallow it, it opens up into a little sponge, and then as we pull it out, it actually scrapes the esophagus. It provides some histology so that we can send it to our pathologist and look to see if they have eosinophils. So ways of trying to see if we can avoid doing an endoscopy. I still prefer the blood test once we get that. That would be much better. Other future directions are, currently we're really at the early stages of treatment. So we're using swallow topical steroids to coat the esophagus. Should we be thinking of biologic therapy? And earlier studies haven't been as promising, and I think that's mainly because it's so complicated. You can see here that there are many factors. I know we focus on the eosinophil, but there are many other cells that are causing inflammation in the esophagus, and they're all related. The most recent therapy is the one in the middle, dupilumab. That blocks IL-13 and IL-4, and that actually shows promising results. So in this randomized trial, you can see that in controls, you have the eosinophils, the black bar is basal zone hyperplasia, and in placebo group, no response, looks identical. In the medication arm, you can see there's a lot of inflammation, and on the bottom right, everything resolves. So no eosinophils, you have the squamous cell epithelium, it looks perfect. And when we look at eosinophil counts, those also improve significantly compared to placebo. So this is promising. It's still in the early phases, but I think it's getting there where we're going to talk about biologic therapy for EoE. Another area of interest is, can we predict who is actually going to develop strictures, who is going to have a more benign disease course? Because right now, we're kind of treating everybody the same. So we treat them with PPIs, we treat them with diets, swallow topical steroids, but a lot of it is trial and error. We don't know who is going to respond to what therapy. And in this study, they once again used gene expression to see if maybe we can tease this apart. And 3 subgroups did tease apart. So I think eventually we'll be able to hopefully predict what medication will work for each individual patient. So ultimately, what I tell every single one of my patients when they come into clinic to see me, I talk about the goals of therapy. And that's 1, if they've ever had a food impaction, I want to prevent it at all costs. That's a terrible thing to undergo, and we want to prevent it. The second thing is I want to improve their quality of life, and that involves dilation so that we can improve their dysphagia so that food doesn't stick. And typically, the goal is to maintain an esophagus above 60 millimeters. For some reason, that 60 millimeters provides the perfect circumference where most people will not feel any food being stuck. It just kind of zooms down. And then also part of it is normalization of the histology, because although we can stretch it, we can open things up, if we don't treat the disease, it's all going to come back. And so it's important to stay on a maintenance plan and make sure that the eosinophils resolve. I would also like to introduce you to our team. So this is our EoE team. On the next to me, we have Emily. She's our new addition to our Eosinophilic Esophagitis clinic. Next to her is Kelly, and behind her is Melissa. They are our dietitians. It is essential to have somebody with you when talking about EoE, because the intricacies of going through that diet, people can have a very difficult time. So I would urge you to send your patients, because it'll make a dramatic improvement. Behind her, you have Donna, who is our medical assistant. Very helps kind of trying to get our medications approved, because they're off-label. We have difficult time getting the budesonide approved. Next to her is Heidi. She's our nurse, and without her, I don't think the EoE clinic would have been able to get off the ground, so she did an amazing job to get this going. And then next to me and behind me is Eric Gomnitz, and he's my mentor friend who really has kind of carried me through this process, and really is who got me interested in the esophagus and EoE. And so thank you, and feel free to email me if you have any questions.
But Dr. Lomeli, take a look, because this is one of the most well-attended grand rounds I have ever seen, which is fantastic. Some people have left, but that's just really a tribute to the topic and to you. So I just
awesome.
want
Thank
you
you.
to take some time to look at that. So questions, everyone? This is obviously an area of great interest.
Yeah.
Yes.
When you say maintenance therapy, how long are you talking about? You start somebody on budesonide when they're 40 and continue with them, for decades? Or?
Yes.
Will you repeat the question?
Oh, sorry, yes. So the question was, what do we do with maintenance therapy? Does that mean that somebody has to be on treatment indefinitely? The short answer is, to this date, yes, because we've been seeing that if we stop therapy, it's going to recur, and if we follow patients over 10 years, it'll continue to be inflamed. But to your point, the other thing I mentioned to my patients is, well, maybe early on, we can use the medications, we can get things cooled off, we can dilate the esophagus, get people to a stable kind of spot, and then we talk about diet. Because I think that long term, although it's a lot of work up front, if we don't have to use medications and people are willing to eliminate that diet trigger, that's the best long-term therapy. So I'm really all for that. Excellent question. Oh, okay, go ahead. Or you can decide.
No,
okay, go ahead.
Yeah, great.
You spoke about how it takes about 10 years to be diagnosed at some point. So I imagine a lot of patients are initially seen in the primary care setting. What would your advice be to PCPs about how a higher index of suspicion and how to not do too much testing and what's the right balance?
Yeah, that's a good question. And it's difficult, honestly, because, sorry, thank you. I remember. So any guidance to our primary care doctors and team as far as, how to diagnose it a little earlier, because there is a significant diagnostic delay, and how to reduce the number of testing that we can do to diagnose our patients. And it is hard, honestly. There's no easy answer because most patients do minimize their symptoms, and they likely won't mention it during a kind of an annual physical or when they're coming in for other complaints. I would say in adults at least, the most common thing that we see is dysphagia. So if they're describing any form of solids sticking, and I always think of anything that can turn to a little ball. So things like meat, chicken, shredded pork, anything like that, bread, even rice sometimes as you eat it, you can imagine, and then it can plug. So those kind of things, it'll tell me that whenever there's dysphagia to solids, that tells me that there's a stricture. It's very common. And if you have the right age group, in their 30s, male, predominantly, history of atopic disease, that should clue you in that this might be EoE. And one way would be to either send them directly to us to see them in clinic, or schedule them for an endoscopy. That's right. Got a question over there? Yeah. I think the gentleman in the back has our hand up first. Go ahead.
So why isn't?
Yeah, go ahead. Yes.
So why isn't there a optimized formulation for a topical steroid?
So the question was, why isn't there an optimized formulation of the topical steroid? And it's in the works. So I think it just hasn't caught on yet, and the pharmaceuticals haven't kind of adapted that and used that, but they are working on that. So hopefully it will get there. And we've actually asked our pharmacies to see, some pharmacies will compound the medication and make it a little easier for our patients to obtain it. But to this date, we don't have one yet. So a great question. Go ahead, yeah.
Relationship between this and Barrett's esophagitis?
Excellent question. So the relationship between this and Barrett's esophagus. Fortunately, although they're a continuum, most patients with EoE, we don't see kind of evidence of Barrett's esophagus. And interestingly, we have not seen a link. Maybe it's because it's early still in its description, but patients with EoE currently do not have an increased risk of esophageal cancer. But we do see the spectrum where patients may have both acid reflux and EoE. And I think in those patients who notice a profound response to PPI therapy, it's important to continue their therapy. Yeah, excellent question. Go ahead.
Has anyone ever explored the possibility of immunotherapy like we use for other agents?
Yeah, no, that's a great question. I didn't mention in the talk. So has anybody explored immunotherapy for this condition? They have, and it's interesting. It's kind of debated. So there's some case reports that unfortunately immunotherapy can sometimes worsen EoE, and maybe the chronic exposures to the esophagus may actually make the inflammation more pronounced. It's hard because it's always a balance. There was another recent case report that described what happens if you have somebody that has an anaphylactic reaction and then you start immunotherapy and they get better. They don't have their anaphylactic reaction. In this case report, they developed EoE. But what's more important, because after they stopped it, they once again went back to the anaphylactic reaction. And then when they reintroduce the trigger. So it's that balance. And that's where it gets really complex. And it's nice to have our allergy colleagues kind of help us understand the pathophysiology of EoE. That's a great question. Yeah, go ahead.
How often do you see thrush in patients that are using these steroids? And are there any tips about how to take them to
Yes.
minimize thrush?
great question. So how often do we see thrush in patients taking these swallow topical steroids? If you look at all studies, estimated about 5% of the time, so it does occur fairly frequently. The most important things are asking our patients, once they take the medication, to rinse out their mouth and kind of just spit everything out, ideally. Ideally, they shouldn't eat anything or drink anything after, because that would wash away the medication. But that's the most important thing. Second, there is a probably higher risk if they're taking other steroids, whether it be like nasal sprays for seasonal allergies. And so at least thinking about that, seeing if that can be reduced. And the last thing is ideally, yes, our initial kind of induction dose is a 1 milligram twice a day, but typically most people can respond to once a day. And so usually if I achieve response, they're having trouble with thrush, then I try to bring it down to the lowest effective dose. And actually that goes along with any medication. Ideally, we try the lowest effective dose so that we minimize risk. Yeah, good question. Other questions?
Thank you very
All right.
much. Come on forward.
Thank you.